Good afternoon, everybody. I'm Dr. Anthony Levinson, a psychiatrist at McMaster University in Hamilton, Ontario, and I'm here today for our 26th iGeriCare live event with geriatrician extraordinaire, Dr. Richard Sztramko.
Also, you say it like that.
Also joining us.
I'm myself like that.
So today's topic is an important one, and I want to say kind of an underrepresented type of dementia or types of dementia. And today's topic is about Lewy body diseases. In particular, we're going to be talking more about dementia with Lewy bodies as well as Parkinson's disease dementia. And as we've often discussed on our multimedia lessons on iGeriCare, as well as in the live events, recall that dementia itself is just an umbrella term that encompasses a number of different diseases, such as Alzheimer's and the diseases we'll be talking about today. Lewy body diseases are a group of neurological conditions basically thought to be caused by these deposits of an abnormal protein. We sometimes simplify things and talk about the concept of toxic proteins. Lewy bodies are things that pathologists were able to see under the microscope, and that these are commonly found in dementia with Lewy bodies as well as Parkinson's disease. So we're going to talk a little bit about the similarities and the differences as well as possible treatments of these Lewy body diseases. So welcome, Richard, and thank you again for joining us this month. Hope everybody's keeping well in your family as well. So, why don't we start off just maybe describe a typical story of a patient with Lewy body dementia that you might have encountered in your practice?
That's great. I think it's a great place to start. So typically what we'll see in patients that have dementia with Lewy bodies is they'll present with cognitive impairment. And the types of kind of memory and thinking or cognitive impairments that they present with are more of the executive function realm. So they have problems planning and organizing and multitasking and things of that nature, and visual spatial function. So they might not be able to construct diagrams, or they might get lost or be wandering off someplace. So they can't recognize their environment, potentially. So those are some common cognitive problems that they complain. One of the most marked features, though, are early onset hallucinations, where people will see things that are not there. So they may see people or animals. They're very well-formed visions as well, usually in the central aspect of the visual field when people are looking around. And they'll complain and see people or animals that are very real and vivid to them, but other people do not see them. So they're a hallucination. The other things that people will complain of, or caregivers taking care of the person with dementia with Lewy bodies, or friends or family, will say that there's a significant amount of fluctuation that happens both in their cognitive capacity as well as their level of alertness or arousal. So you might find them at the beginning of the day will be very alert and perform very well on testing and go about their day-to-day activities. But later on in the afternoon, they might be slurring their speech a little bit. They tend to sleep quite a lot as well. So you might find people sleeping 4 to 6 hours per day. And it fluctuates within the same day and from day to day. And I'd say I didn't really get this. You heard the fluctuation part of it. But when I was a research fellow, I actually got to test somebody or see somebody twice in the same day. So I interviewed the gentleman first thing in the morning, and we did a lot of cognitive testing. And then I got to review him at 2 o'clock in the afternoon and see him on the same day, which you never get to do really with patients. You only generally see them once a day. And he was just a completely different person from morning to afternoon. And I think that's one of the most under-recognized features of this illness.
I totally agree. I'm going to talk a little bit about some of my both personal and professional experiences with Lewy body dementia. I think just to start with the fluctuation part and then go back to the hallucination part. With the fluctuations, because you and I sometimes work in the hospital setting, in the inpatient hospital setting, many of the patients that we see who eventually wind up being diagnosed with Lewy body dementia are often initially diagnosed with delirium. So people aren't necessarily thinking, they may be aware of cognitive decline, but they often present with delirium. You can't seem to find another cause. While they're in the hospital, the sleep disturbance is also noticed. And we're going to talk a bit about REM sleep behavior disorder in a second. But it's a real challenge, I think, if you're a caregiver at home, because you've been told, oh, watch out for the signs of delirium, which might include, fluctuating levels of attention. And sure enough, the person with Lewy body dementia can really look like they have delirium. And then all of a sudden they seem to sort of snap out of it and may have stretches of days and weeks when they don't necessarily have these episodes. But I think really hard to recognize, hard to differentiate from delirium before the diagnosis of Lewy body dementia is made, and very vexing, I think, for the people living with Lewy body disease, but also the caregivers who are concerned. And just the hallucinations, they're not always frightening, but they always seem to be vivid. And while we talk, so the types of visual hallucinations, people will talk about snakes a lot, seeing snakes moving on the floor. It's very frightening, but they are also sometimes amenable to suggestion. So using cognitive techniques, why don't you just walk around them or some, so there are some interesting sort of practical strategies if the person is having these really vivid hallucinations. Sometimes they're not of unpleasant things, and sometimes they're auditory. You may hear music playing. It's often the consistent kind of music, just like with the visual hallucinations. There's often recurrent themes, and as you say, animals are not uncommon there. So, but really prominent. So, totally agree with your characterization of those experiences, and both of those things, the hallucinations and the fluctuation, can present challenges for the people living with the illness as well as care partners.
Those are great points. The final thing that we'll come to in this kind of core set of features is the Parkinsonism. And so I think that's the reason we're putting this last in this case, is because when you hear that first initial story, it's just a very unique story and experience that people with dementia with Lewy bodies have. When it gets to the Parkinsonism side, it makes sense to define what Parkinsonism is. So Parkinsonism is a syndrome as well, and it has to do with the motor movements or motor system in your body. And the core features include tremor. Usually what most people will think about is a bit of a rest tremor, a rolling tremor. But it can also be a tremor on movement. So a high frequency, low amplitude kinetic tremor can also be associated with Parkinsonism. People will complain of slowness of movement or bradykinesia. So what you'll see on testing is that, normally if you're able to do this with your fingers quite quickly, you'll see people slow down and pause or have intrusions where they stop movements or the amplitude of their movements go down. And there's various ways that we can test that. But the way you would see it as a person experiencing it or as a caregiver would be the slowing down of movements as well. Rigidity is another core feature. So when you take somebody's arm and you are moving it passively, meaning they're not trying to, their muscles aren't engaged, you're moving it, you'll feel consistent resistance about the joint. So if it can either be lead pipe or it's just a consistent resistance, or if you feel a bit of a ratcheting feeling, it's called cogwheeling rigidity. And the last thing people will note is postural instability. So the brainstem reflexes that are involved in keeping you upright and making sure that you maintain a sense of balance and in your environment can also be impacted. And so people will feel unstable and sometimes present with early falls. On testing, when we move people around, they might not necessarily be able to balance or right themselves. When people think of Parkinson's disease, and we'll get into that in a second, people will notice this. The more common presentation would be just the motor symptoms. So somebody might just notice that they have this tremor, or their ability to coordinate or do fine motor movements with their hands will be an initial presentation. Whereas with dementia with Lewy bodies, it's more of a secondary feature, and it's not the feature that's driving their impairment day to day and impairing their quality of life the most generally. It's usually more of a mild form of Parkinson's. Although that being said, there's lots of overlap, and we're trying to separate them out very clearly. But as we'll get into a little bit later on, there's definitely lots of overlap. So just to review, it's the dementia or cognitive impairment that happens along with visual hallucinations, fluctuations in cognition or alertness, and Parkinsonism. The supporting features are REM sleep disorder, and what will happen to what patients or their caregivers, often their caregivers will notice is that, normally when we're asleep and we're in REM sleep, the REM sleep stage of cycling through our kind of usual sleep architecture every 45 minutes, we cycle through various degrees of sleep. When you reach REM sleep and you're having these dreams, your brain normally tells your body to lose all muscle tone so you can act out your dreams. And in dementia with Lewy bodies, you can have this REM sleep disorder where people will start talking quite loudly or screaming in their sleep, moving their arms. And sometimes it can be quite violent where people will thrash around. It's very important to counsel caregivers because sometimes they can get injured if people are thrashing around too violently. And then I think the other thing we'll mention is just the neuroleptic sensitivity. So there are antipsychotic medications that are sometimes used in the context of psychiatric illness, or other times when people are acutely confused in hospital and delirious. And if people are given a medication that strongly blocks dopamine, people will have a very abrupt worsening of their dementia, or they'll have an abrupt worsening of their Parkinsonism. So they can become very tremulous or rigid.
It's probably worth saying that people with Parkinson's disease will also typically worsen with those same category of antipsychotic medications as well. And as we'll talk about in a second, medications are one of the causes of Parkinsonism or Parkinsonian symptoms. So there are other conditions apart from Lewy body dementia and Parkinson's disease that can cause some of these similar symptoms, which we'll talk a little bit about. But the REM sleep behavior disorder, often very frightening to care partners. As you say, they're acutely aware of it if they're still sleeping in the same room. I would say half the spouses have left the room because of REM sleep behavior disorder, and they're no longer sleeping in the same bed a lot of the times because of the flailing about, maybe not like actually getting injured, but the sleep being so disrupted because of the movements and noises. And it's almost like somebody who with REM sleep behavior disorder is kind of acting out what's happening in their dreams. And so, it's very disruptive to the sleep of the care partner. A couple of the other things, just almost a bit of a recap in terms of some of the things we've talked about here. So we have this sort of broader family of Lewy body disease. The two that we're focusing on today, Parkinson's disease dementia and dementia with Lewy bodies, but there are some other disorders like multisystem or multiple system atrophy or MSA. And to some degree, what you've just talked about too is you have these symptoms of Parkinsonism in dementia with Lewy bodies, and that kind of overlaps in some way with Parkinson's disease, which, maybe that'll be helpful to, now that we've talked about sort of some of the typical features and classic stories of what people with Lewy body dementia go through. But there's an overlap between these different syndromes and symptoms, so that you have symptoms of Parkinsonism in dementia with Lewy bodies, and you have overlapping symptoms and other symptoms related to the multiple system atrophy that affect other parts of the nervous system. So the automatic or the autonomic nervous system is often affected, and people may have issues like constipation or urinary symptoms in these disorders, as well as the postural ones, where they may get lightheaded, they may have falls or changes to their blood pressure as well from this.
I think,
and then just, sorry, go ahead.
Yeah, no, I think it's worthwhile to note in that if you listed all possible symptoms, any one of these disorders could check off any one of the symptoms that we're talking about. But it's more the strength of the symptoms and when those symptoms are starting within the course of the illness generally. So, we talked about the cognitive impairment and hallucinations and fluctuations being a stronger component or stronger flavor with dementia with Lewy bodies. And with Parkinson's disease, usually it's more the motor symptoms we talked about. So those trap features, and people will struggle with their tremor and their fine motor movements to a significant degree. So they're not complaining necessarily about their memory and thinking is impacting their life. They're saying, this tremor is impacting my ability to eat, or I can't open jars the way I used to, or my writing's gotten really small. And when you hear that story, that's a much different story than I've got really bad hallucinations and fluctuating a lot. And that being said, over time, the people that have Parkinson's disease and have the motor symptoms for a period of time, generally they can get hallucinations as well, but it might be 3 or 4 years into their course of their illness, and they might not be quite as vivid. There might just be floating things in their peripheral vision.
I do think that there are also important cognitive changes, and certainly we see a lot of psychiatric symptoms and syndromes in patients both with Parkinson's disease and Lewy body dementia. But I do think there's maybe an underestimate of some of the other cognitive and psychiatric changes in Parkinson's disease, even before it might go on to dementia. We know there are higher rates of depressive illness and anxiety, and even like cognitive slowing, even if it doesn't necessarily meet criteria, say for dementia. So while you're absolutely right, people tend to sort of say, well, in Parkinson's disease, the motor symptoms are the most prominent and are there, at least a year before some of the other changes. And then in Lewy body dementia, you're seeing those other really prominent cognitive changes, hallucinations, and the sleep behaviors. So
you're absolutely right. And so let's say and again, but that's almost like a different flavor too. So apathy, depression, and anxiety are the most common earlier symptoms in Parkinson's disease without dementia. That makes sense. But even that's kind of a different feel. Like I've got a really bad tremor and bad motor problems and I'm depressed, or I don't feel like engaging in my day-to-day activities is a different story than, the one we described with dementia with Lewy bodies. And it is important. Like what you're bringing up is that the psychiatric manifestations are under-recognized and underdiagnosed. And if people with Parkinson's disease actually rate what impairs their quality of life the most, it's the non-motor thing. So like, well, you want to focus on treating the motor symptoms, and we can do that with dopaminergic agents. So you can treat the motor symptoms quite effectively for a long period of time in most people with medications where you bump up the levels of dopamine, and it can improve the rigidity, and it can improve the slowness of movement, and can certainly improve the tremor. The challenge, though, is that the non-motor symptoms, so anxiety, depression, apathy, and then sometimes later on hallucinations, delusions, or the autonomic symptoms you were discussing, the sleep problems, people like, these are all the things that really impact me the most. And so you definitely need to do a comprehensive review of all of these patients and find out what their symptoms are.
There, certainly what we were talking about before, that many of the patients with later on in the stages of Parkinson's disease, and certainly in Lewy body dementia, do have psychiatric symptoms like hallucinations and delusions. And while those often do respond or improve with antipsychotic medications, the side effect, one of the major side effects of antipsychotic medications is worsening Parkinsonism. So it can be a real challenge to manage those symptoms. And of course, some of the medicines that are used to help manage the Parkinson's by replacing the dopamine can actually cause side effects of hallucinations. So it is a real delicate balance in patients with Parkinson's disease and Lewy body dementia who have prominent symptoms like hallucinations or delusions, to manage those with very low doses of antipsychotic medicines, and just continue to try to find that balance between the benefits and the adverse effects. I'm gonna shift to questions, because we have a lot of great questions coming in, and I want to thank people for participating today, sending in questions, as well as those people who submitted them in the past. I'm going to try to stick to some of the items that are directly related to Lewy body dementia and Parkinson's disease dementia, but if we have time, we'll try to address some of the more general ones as well. One person sent in an excellent resource, which I'll put up again at the end. The comment is whether we were aware of the research that Dr. Stephen Pasternak is doing. He's a neurologist and professor at the Robarts Research Institute at the Schulich School of Dentistry and Medicine. And then a more general comment: why is there so little coordination, research of Lewy body dementia across Canada, or more coordinated information for those who've been diagnosed with Lewy body dementia in Canada and their families? Many in the medical profession don't even know about Lewy body dementia. I started our Lewy body dementia website for that reason, www.canadianlbdinfo.ca. And I'm going to put that link up at the end as well. Some folks still don't understand that dementia is the umbrella word, and that Alzheimer's, Lewy body dementia, hypoxia, frontal lobe dementia, and Parkinson's with dementia are various forms of dementia. So thank you very much for sending in that excellent resource. I will put up the CanadianLBDinfo.ca website again. And I would agree with you wholeheartedly, both personally and professionally. I think this is probably an under-recognized illness, and one that is probably underappreciated, and there aren't maybe good coordinated resources. I like to think that's improving. And I do think there's more coordinated networks doing research generally in dementia. And I think those are including Lewy body dementia as well. There seems to be a little bit more funding as part of the national dementia strategy to do a better job at coordinating research more broadly, not necessarily specifically about Lewy body dementia. Any other thoughts from you, Richard, about that coordination of research and attention to Lewy body dementia?
It's a tough one, because there's definitely a lot more coordination taking place. Like, there's a Canadian Consortium on Research on Neurodegenerative Diseases. that coordinates randomized control trials for all neurodegenerative diseases across many different sites in Canada, both academic and non-academic. So there's definitely more coordination happening for dementia research, but even a lot of the calls that I see come out for disease-modifying therapy, let's say, it's not commonly just for dementia with Lewy bodies, unfortunately, right? Like nobody even has a good treatment for Alzheimer's yet. I mean, there's stuff in the wings that's coming out, right? We'll see how that goes, but it's still the amount. So it's increased, which is awesome. I totally agree with what you're saying. It's trending in the right direction, and I think physician awareness is trending in the right direction. Getting more geriatric training and basic skills into medical schools and residency programs is increasing the awareness. And I think I've seen a trend overall, generally in the field, right? People are a lot more aware of the consequences of delirium and what a bad state that is. And similarly, now they're starting to recognize dementia with Lewy bodies as a really important disorder to kind of take part of.
I would be more work to be done on continuing advocacy and training around it. So here's a good question: how is Lewy body dementia diagnosed, and is treatment heavy meds? I'm not sure if that means if treatment is predominantly medications, and what if they don't work?
Yeah, the most effective treatment for dementia with Lewy bodies, given the most common symptoms, is a cholinesterase inhibitor like Aricept. It works well for psychiatric symptoms, for the cognitive problems, and most importantly for hallucinations. So on brain scans of people with dementia with Lewy bodies, there's low blood perfusion to the parts of the brain that process visual inputs and probably manifest the hallucinations, and you can actually reverse that with cholinesterase inhibitors, which is great. So that's always my first go-to, and people can have quite a lot of relief for some period of time, especially with respect to the hallucinations. Sometimes it's they're a bit of a miracle drug. And then if the motor symptoms are bad enough, people can certainly go on dopamine-related medications like Sinemet. They're less effective in people that have dementia with Lewy bodies than they are in Parkinson's, and often you're limited by the side effects, but it is a possibility. I find most often I don't have to use them because the motor problems more commonly are not that bad.
Here's another question: with the individual's fluctuations, when do you suggest doing cognitive testing, like the mini mental status examination or a MOCA? These are bedside cognitive tests. So when do you suggest they get completed to get the most accurate picture of the individual's cognitive abilities?
I mean, that's a tough one, because I mean they're both accurate for the different state that you're in. I don't think we don't have a policy that we test certain people at certain periods of time. We just test them, and generally, I haven't noticed it make that big of a difference in terms of your overall clinical diagnosis. Much of your assessment of where people are at on their continuum of disease is really their functional day-to-day activities. So you can tell, like, if they stop paying their bills because they're forgetting to pay their bills and they can't do their finances and they can't organize themselves to get shopping, or it's severe enough where they're needing help with their basic activities of daily living, like, queuing to get out of bed and getting bathed and things like that. That often will tell you a lot more than a number. Oftentimes the numbers or the tests are a lot more helpful earlier on in the disease. And then after that, you're really dealing with a lot of the psychiatric symptoms that we were discussing as well, and putting kind of functional supports in place.
And I think when the fluctuations are really severe, it's almost impossible to do any sort of bedside testing. So this is a comment, I guess, this is a person who was asking about what that medication you just were talking about that might be helpful for hallucinations. They want to compare to what their mother has. So you mentioned the cholinesterase inhibitors as a class. These are also sometimes called cognitive enhancers, and I think you mentioned the drug Aricept as one example in that class of medications. So, there was a comment about what needs to happen is doctors to be informed about the antipsychotics so they stop harming our loved ones. And there's definitely there's been several educational initiatives, and I think one of the Choosing Wisely campaigns looking specifically at deprescribing antipsychotic medications, specifically in congregate care settings like long-term care homes. So I think there's there's data that sometimes people may get started on antipsychotic medications for responsive behaviors, but they just sort of keep prescribing them and don't necessarily ever deprescribe them. So I think there's increasing awareness, but it's obviously an area where I think there needs to be ongoing education and probably systemic quality improvement programs, which I think have been shown to be more impactful than just individual education initiatives. So.
It's an interesting one though too, because I think probably with our experience, like the specific indication that you're prescribing medication for, if you have a very good understanding of these diseases, like sometimes these antipsychotic medications are the best thing ever for the patients because they're suffering so much from their psychiatric symptoms. So if you're being very specific about why you're treating the patient and you're an expert and you understand all of the risks and benefits, you can counsel the family members and the patient on that. And you know what side effects to look out for or adverse drug reactions, they can be extremely effective medications. And so I'm kind of a little bit on the other side. I feel like almost in some ways, like for everybody across entire populations to maybe not prescribe them so easily is a good thing and people to understand it. But if you're prescribing it, I would trust your ability to prescribe it, or if I'm prescribing it for very specific indications, I'm a big fan. It's the compassionate thing to do to provide people with the highest quality of life sometimes.
Well, we were just recently involved in the care of somebody who had a very dramatic improvement on a very low dose of an antipsychotic medication, but a plan to continue to review that on an ongoing basis. And I think what happens sometimes is that review on the ongoing basis and what was the indication, nobody is really attending to those things and examining regularly for adverse effects. So we're getting a lot of good questions. So I want to keep going. This is sort of going back, I guess, to the issue around diagnosis. And it sort of said once a bedside test like a MOCA is done, how is Lewy body dementia sort of officially diagnosed? Are there other investigations that would be done? And would the diagnosis typically be made by a family physician, or would there be other specialists involved in a diagnosis of Lewy body dementia?
There's no one test. It's a clinical syndrome again. So just like all forms, we take into consideration what the symptoms that the patient is talking to us about, the physical exam findings, the cognitive testing, blood work, and pictures of the brain. And you kind of put that all together to come up with the syndrome. And sometimes we don't know, like after somebody passes away and we look inside their brain, like sometimes we don't get it right, but oftentimes we do, 80 to 90% of the time for Alzheimer's disease. And I'm sure it's getting better for dementia with Lewy bodies as well. So it's that clinical diagnosis. And I'd say for the most part, people will tell very compelling stories and provide physical examination and cognitive pictures that allow you to differentiate them. And then there's sometimes where it's not exactly clear. And then you state that. It's like, there's somewhere in between a Parkinson's disease or dementia with Lewy bodies, and it's hard to differentiate. And in those cases, oftentimes it might not be as important because you're just intervening on the end symptoms. So I'll treat your depression effectively if you have that. And if you have hallucinations, I'll focus on that. And if you're falling, I'll focus on that. And if you're really constipated or having urinary frequency, focus on that. So I think it's really helpful for counseling patients in terms of providing them with a diagnosis. But even in the situations where patients don't get a specific diagnosis, you can lean them in one direction or the other, and it certainly doesn't prevent you from treating them at the end of the day.
Just while we've been talking about diagnosis, and you mentioned brain imaging, there was a question that came through about whether PET scan can be diagnostic in any way, and how accurate are PET scans?
They're not. It's a bit easier for something with like Alzheimer's disease, where you have really poor perfusion to the medial temporal lobes and parietal lobes and occipital cortex. With dementia with Lewy bodies, I haven't seen a lot of evidence for the PET scan per se. I know there's a dopamine uptake scan that's quite specialized, a DAT scan that the neurologist will order, but only in they almost never do it because it's a lot easier to diagnose somebody syndromically. One of the highest specificity or sensitivity specificity tests is a MIBG scan, which basically looks at catecholamine uptake in the heart, which is interesting, but it's mainly used in research purposes. Again, because for the most part, you're going to be able to separate people based on their clinical picture. So, and I think too, like one of the most important reasons, obviously, every patient and family deserves the best or clearest diagnostic picture possible so they can understand what's happening to them and put their personal life narrative and illness experience in the context of the rest of their life. But the neuroleptic sensitivity thing is one of those really important parts about dealing with Parkinsonism and especially dementia with Lewy bodies, because they experience it, to such a significant degree. To be able to put that on somebody's, chart to try and prevent them from having these sensitivity reactions.
I've got just so many other questions coming through, and some that were sent through before. I'm going to lump together these two. This is somebody who said, my mother had Lewy body dementia. How possible is it that I will get it? And is there a test that can determine this? And somebody else also sent in a question about, is there any role for genetic testing?
Yeah, it's a very similar response to Alzheimer's disease. So if you have a first generation relative, you're at a slightly increased risk, but there's no specific test or way to quantify that risk specifically. If you have early onset disease, or you'll see things inherited through your family tree in a specific pattern, usually autosomal dominant, but I'm not a Parkinson's disease or Lewy body or alpha-synuclein expert. But generally, if there's that pattern of inheritance or more early onset disease, there are specific genes that you can get tested for. I think the PARC or LARC genes are some of the genes that can cause Parkinson's disease. But again, those are very rare. By far and away, it's not an inherited problem.
Here's a very specific question, which maybe we can convert to more general discussion about dopamine agents. So this is somebody who says, we're on ropinirole 4 milligrams a day and levodopa, which is Sinemet 100/25 milligrams, because Sinemet is a combo pill, 4 times daily. Is this a good medication for this problem? So it's unclear whether the person's talking about Parkinson's disease or Parkinson's disease dementia or Lewy body dementia, but maybe just speak quickly about dopaminergic agents more generally.
Yeah, so levodopa, carbidopa is a combination drug where it's a bit of dopamine and a bit of another agent that prevents you from getting side effects from that dopamine. And the ropinirole is a dopamine agonist. So one is just basically direct dopamine into your system. The other one, you put it into your system and your body converts it into dopamine. There used to be a lot of discussion about, whether being on Sinemet might alter the progression of your Parkinson's disease and make it progress somewhat faster, or make you develop abnormal movements, which are called dyskinesias, that will take place in Parkinson's disease. But that's line of research has fallen out of favor. So basically, you can pick Cinemet, where you can pick a dopamine agonist. Very rarely will you overlap them unless somebody's experienced dyskinesia. So this treatment regimen here looks like the person's dealing with Parkinson's disease as opposed to Parkinson's disease dementia. And the only way to tell is if your symptoms are well controlled on that and you've mitigated the side effects. So the problem sometimes with dopamine agonists is people will get something called dopamine dysregulation syndrome, where they'll partake in riskier behaviors. They might start, gambling or get involved in bad property deals or buy or spend a lot of money, buy a lot of things or spend a lot of money. So I think that's something to watch out for. And it's really a different experience for people if they're developing symptoms earlier on in life, like in their 50s and 60s with just a motor issue versus, developing it in their 70s and 80s and have other medical conditions and might have a milder form of disease.
I think there was a follow-up from the person who's watching live saying that the problem had been diagnosed as Lewy body dementia with Parkinson's. So I guess probably functionally the motor symptoms, the Parkinson's symptoms were pretty functionally disabling. So that's probably why. And the thing to watch out for there would be the adverse effects of the hallucinations that might exacerbate the hallucinations of the Lewy body dementia potentially. Actually, sorry, go ahead.
Always use the lowest dose possible to control symptoms because of the issues you were talking about. There are people that can have Parkinsonism and not require any treatment for either a long period of time because functionally day to day they're doing well, or never require it. So, and then you're just slowly increasing the dose of these medications to a point where you get enough control that you're comfortable with your day-to-day activities, and then you don't push it up past that because of the risks of side effects. And then over time, as the illness gets worse, you can, again, slowly increase the medications at that point in time to improve symptom control. And so you will notice that as the disease progresses, as people generally tend to be on more medications at higher doses, and the dosing interval between the medications, especially for Cinemet, tends to shorten.
Yeah, and at a certain point, the body's own ability to take the Cinemet and convert it to dopamine to benefit the motor function diminishes as the disorder progresses. So there becomes a point of less response to those dopaminergic agents. Are you able to stay a little longer today, Richard? We've been flooded with some really great questions, so I'm gonna try to wrap up some of the ones, but I think we might stay a couple minutes longer. There was just a question: can you comment on hallucinations and fixed delusions? So hallucinations are typically experiences we have of the senses that are not based on something real. So visual hallucinations, like we described, as often occur in Lewy body disease and delirium, where you might see things that aren't there, animals on the wall, things like that. Delusions are fixed false beliefs, often things like paranoid delusions, where you're sure that somebody's sneaking in and stealing your things or something like that. So these are symptoms that can occur in any of the dementias, and the hallucinations are particularly common in Lewy body dementia, but they can occur in others. And it's also important to realize that delusions can occur in other psychiatric conditions. So if somebody has a very severe depression, they can develop psychotic symptoms like delusions. And they're often ones that are what we call congruent or consistent with a depressed mood. So people often have delusions about maybe their body is rotting, or that they've caused something bad, or that something catastrophic is going to happen. So again, very important to differentiate some of these different symptoms and syndromes. Please discuss hallucinations with Lewy body disease. Sometimes it can seem that my father may just be confused, seeing me as my sister or aunt or mother, but I'm having difficulty interpreting this as confusion versus hallucinations. That sounds more like confusion or memory issues, whereas hallucinations more typically are, seeing animals or other people who aren't there in the room. So maybe imagining that he's seeing your sister when your sister hasn't been there to visit, that would be more consistent with a hallucination rather than just confusion. There is a delusion where people sometimes think that their family members have been substituted by other people. It's actually quite a common delusion, but it's not usually one family member substituted for another. It's usually like aliens or foreigners or other people substituting for the family member.
I guess that's the other possibility where it's like it's a visual spatial misperception, just not recognizing somebody's face. But that's not somebody else that's not there.
There were a couple of interesting questions. So here's a question from Ottawa. Can the immune system be triggered to stop the Lewy bodies from forming? Can the condition be reversed? And does food play an important role in how rapidly the condition is progressing?
Well, these are all great questions. So I think there's been no direct vaccine trials in dementia with Lewy bodies that I'm aware of. But again, I haven't looked at this recently. There were in Alzheimer's disease, right? Where you vaccinate somebody and you teach your immune system to recognize the toxic protein. Your immune system attacks the toxic protein and is able to take it out of your brain. So if you take a picture of your brain before the vaccine and after, you can get rid of the protein, but they don't notice a lot of cognitive improvement. So there has been some study in that area, not successful to date in terms of trying to figure that out. There is also another question, which is separate, whether these diseases are a consequence of your body attacking itself. So autoimmune disorder, there's quite a lot of research happening in that. I saw an article published in one of the major newspapers last week, but again, it's too far off to say that. I don't think so personally. Like, there's a lot of other reasonable explanations for them, but that's not a great explanation today.
That was one of the other comments somebody had was, hey, they're saying Alzheimer's might be more like an autoimmune issue. Maybe they'll be testing for that in the future.
There's kind of like the theory. Sometimes there's like the theory of the day that keeps kind of going through. And the real answer is like, if the real science was in and people knew, you would know and it would be clear. But oftentimes it's just kind of reporters picking up on a scientific hypothesis, which hasn't been proven yet, which is what the autoimmune disease. There's also really interesting stuff on the mouth microbiome and gingival inflammation and bacteria from your mouth being found in your brain. But again, it's an interesting hypothesis.
For live event 100, we'll be there. That's right.
We'll get there. Let's do it. Right. I think that was the other question. It's not that nothing's been found in Parkinson's disease or dementia with Lewy bodies or multi-system atrophy to be reversible yet.
Yeah, and actually that was one of the other questions about anything to reverse the symptoms, and no. And I guess back to just the point about food or diet, while nothing would be reversible, we have talked previously about certain diets that have been shown more generally to promote brain health. So things like the Mediterranean diet, looking after those other types of risk factors that might worsen Lewy body dementia, but it doesn't seem to be directly related to the Lewy bodies. Here's another comment. Is there an association between amyloid plaques and Lewy bodies?
Well, this is a great question. This is like a higher level, this is like a university level question compared to the basics that we've been kind of getting before. So when you cut open the brains, and so focus on everything we've said to date. Like, don't focus on this part because this is where it gets a little bit confusing even for people like us. Whereas like if you look at the brains of people that have Parkinson's disease or dementia with Lewy bodies, and you look at the Lewy bodies, the distribution of them is not that different. It would be nice to say, hey, all of your Lewy bodies are in the cortex or the higher part of the brain, you've got dementia with Lewy bodies, or hey, all of your Lewy bodies are in the midbrain or the substantia nigra, you've got Parkinson's disease. Unfortunately, it doesn't look like that. There's a lot of overlap pathologically. Again, with the caveat that I'm not a neuropathologist. However, in people that have dementia with Lewy bodies, frequently there's overlap. And when you cut the brain open and do like an autopsy and look at it under the microscope, there's Alzheimer's disease, beta amyloid and tau present with the Lewy bodies. And it seems like the presence of the Alzheimer's disease actually impact the overall course of the dementia with Lewy bodies. So the truth is that in some cases, there's a bit of overlap, and we don't know exactly what that means yet.
Here's a question from Hamilton. I'm going to try to be super brief so that we can try to wrap up. If you do have to leave the live event, don't worry. Remember, we record all of these and make them available on our events page as well. So this is a question: is there a difference between Lewy body dementia and frontotemporal dementia? And I will say yes. There are two separate conditions. Actually, frontotemporal dementia is possibly even multiple different entities, but their characteristics are different. Probably the best approach would be to go through the iGeriCare lesson called The Types of Dementia. And in that lesson, we do give sort of a snapshot of 5 of the more common types. And frontotemporal dementia doesn't have a lot of the characteristic symptoms we've been talking about, the hallucinations that one sees in Lewy body dementia, the Parkinsonism that one can see, and the REM sleep disorder. Those things are much more characteristic of Lewy body dementia, whereas often behavioral symptoms early on in the course of the illness are more characteristic of frontotemporal dementia, psychiatric symptoms, or in some cases changes to language. But yeah, probably best to review the lesson. Here's a question about response or lack of response to antipsychotics in Lewy body dementia. As you've talked about and mentioned, people with Lewy body dementia are often exquisitely sensitive to antipsychotics that block the dopamine. So in general, they are a drug of last resort. And if they are going to be used, they're used at very, very low doses and monitoring very closely to see whether or not it might be making the other motor symptoms worse. Mostly the cases that I've been involved with, we really try to avoid use of antipsychotics. I don't know if you have any other comments on that, Rich.
No, I think so. I think something too that might have happened is that I've noticed is that over the last 10 years, the starting doses, like people are starting to wisen up a little bit more to the starting dose. Like they're not just like, oh, here, take a milligram of risperidone twice a day. It's like,
yeah,
you take 0.25, and people are just a lot more aware. So I wonder if a lot of the sensitivity that was taking place was like, I mean, they held all 10 or 5 instead of like 0.5. And so there's been a lot of people that they can't tolerate other medications. Like oftentimes we'll try quetiapine first and it's too sedating for them. And then they don't want to be on clozapine because they don't want to get their white blood cell. And then finally you put them on something that they might have a sensitivity reaction to, but they don't end up doing it because you were very careful at how you do it and how closely you follow them. Somebody mentioned that the PET one in the 90% accurate.
Yeah, that was somebody who had been told that PET is a PET scan is 90% accurate diagnostically.
I just pulled up a study just to check that out, and it looks like there is a study with 72 patients that showed that it is 90% active or accurate. I think and it improved it for people that were early in the course of their disease. So I think maybe if you had uncertainty, then you could go ahead and get a PET. The problem is that they're so hard to get because they're used predominantly for cancer patients. And a lot of times, if we don't think it's going to change our diagnosis, then we won't get them. But I suppose if there is some diagnostic uncertainty, you could push to get it done.
I am going to try to wrap up, but I want to address some of the last few questions. But then I'm putting a moratorium on new questions so we can try to wrap up. Did I say the Mediterranean diet is a healthy diet for your brain? Yes. Recommend our lesson on promoting brain health. Are the hallucinations the difference between Alzheimer's versus Lewy body dementia when trying to diagnose? You can absolutely have hallucinations, usually later on in the course of Alzheimer's disease. Prominent, fully formed visual hallucinations are quite a bit more characteristic of Lewy body dementia. So that would be one of the differentiators. But again, you're going to look at the whole story. What are the other features when differentiating them, and not just focus on the one? Hallucinations are also quite common in delirium. So again, there's other things that you need to be attending to. We did have a question that was unrelated to Lewy body that came in. Is ECT an effective treatment for Alzheimer's patients who cry frequently and appear to be in distress? ECT, also formerly known as shock treatment, so electroconvulsive therapy. It's a treatment typically reserved for patients with severe depression, but can be used in some other indications. And actually, people with dementia and severe depression, if they have not had a response to appropriate medication trials, then actually it is appropriate for a trial of ECT in somebody with dementia who has severe depression that hasn't responded. But they are more likely to develop certain side effects like delirium, and it's I would just say you'd really want to be confident that you were treating a depression that hadn't responded to another treatment, and not just some symptoms. So most of the studies that have looked at ECT have really looked at it as a treatment for depression, but it can be effective for people with dementia and depression. The other question was around isolation during COVID. Is there any evidence that dementia in geriatric individuals is affected, either found to be hastened or instigated by the conditions of COVID lockdowns and isolation from others? There's new data that is emerging, because there haven't been, as you can imagine, a lot of high quality studies in this area, but some retrospective studies that looked at the lockdown in Italy as well, did show a couple of things that we can say. Dementia was a strong risk factor for in-hospital death in patients over 80. COVID pandemic measures in Italy seem to induce worsening of cognitive decline in people with dementia. But again, not super strong data. And I think the last live event I was saying that I started watching a presentation from Parminder Raina from McMaster's Institute for Research on Aging. He was talking about some of the data from the CLSA, the Canadian Longitudinal Study on Aging, and I believe he was showing greater impact in terms of psychiatric syndromes like depressive syndromes, but I don't think he it wasn't designed to look at, is it a lockdown measure or what's happening with cognitive symptoms? So I think we'll probably get more data emerging as people have a chance to, look at some of the research there. I think we'll wrap up here. I really want to appreciate all the questions. I apologize if I didn't get to everybody's question. I just want to quickly put up a couple of the resources. So again, our iGeriCare resource, Michael J. Fox Foundation and Parkinson's Canada have very good information about Parkinson's disease. Thank you for sending in that link on the Canadian Lewy body dementia information. And also, if you get a chance to watch the Robin Williams documentary, I found it to be very compelling, and did also provide a really in-depth story about somebody living with the symptoms of Lewy body dementia as well. As always, I want to thank Dr. Sztramko. iGeriCare was developed with support from Canadian Centre for Aging and Brain Health Innovation, powered by Baycrest, the Jarrett Centre at Hamilton Health Sciences, McMaster University, the Hamilton Health Sciences Foundation, our local Alzheimer's Society Foundation for Hamilton Halton, and our Division of E-Learning team, still cooking at home during the pandemic. We're going to have a little break in June. We're a little too busy, but the next live event is currently scheduled for Thursday, July 15th at 1. There's a survey pinned at the top of the comments section. Thank you all for joining us on this really important topic. As always, teamwork makes the dream work. We'll see you in July.